Okay, moving on now to the next chapter in the book, which starts on page 43, HIV/infectious diseases. And again, I have no conflicts of interest in relation to this particular chapter. And once again, the objectives for the particular chapter are listed on the top of page 44, and you can read through those on your own. And again, for time reasons, I'm not going to go through those and just read them to you. So this morning I am going to be going over four main areas. Actually, the first three are the main areas, and then the antifungal therapy is more of an FYI for all of you. So we'll talk about HIV and treatment of HIV. Then we'll talk about HIV-related opportunistic infections. We'll go over tuberculosis, and then we'll conclude by basically I'll let you know the parts of the chapter that have to do with antifungal therapy, and you should read through that on your own, especially if you work in a community practice, because some of those antifungals you probably haven't seen that much. I do want to say that the HIV guidelines are updated constantly, so this happens all the time where my chapter's done and everything's completed and then the guidelines get updated. So the guidelines were updated in February 12th of 2013. They weren't changed that much. A few relatively minor changes, and as those changes come up in relation to the information I'm talking to you about, I will have bolded things on the slide or crossed things out on the slide, and I'll make a specific note of those changes. Remember, though, that as far as the exams are concerned, the questions are prepared far in advance, so any of these quick changes in guidelines are not going to be reflected on the exam, and the changes in HIV are so minor that they wouldn't have affected the exam anyway. I'm going to start with a little background information. The first has to do with transmission and the three main types of transmission: sexual, parenteral exposure to blood, and perinatal. And then you can see the risk factors which are there on the pie chart on the right side of the screen. So men who have sex with men, IV drug users, combination of those two, heterosexual transmission, and other. And these are data from the U.S., not world data, but data from the U.S. I also have information on universal precautions. That's under Table 1, so if you're unfamiliar with universal precautions, you might want to read through that. And also there's new information on pre-exposure prophylaxis, so that is as well on the top of page 47. Information on people that aren't HIV positive and using agents in order to prevent them from getting the infection. And you can see right now that's only recommended in men having sex with men. And then the antivirals that are recommended are also listed there. So this is, next three or four slides are from the CDC, just epidemiology information from the CDC. So this goes through the rates of HIV infection by transmission category. So you can see male-to-male sexual contact and heterosexual contact, IV drug use, etc., going down. You can see the rise in most of the categories until about the mid-90s when therapy really blossomed and we had a lot more therapy for HIV. And then the rates have gone down and has sort of stabilized. There's a little concern maybe if there's a blip coming up, but we'll have to wait a few more years in order to look at the data and see if that's a consistent blip going up or whether the incidence has stabilized. This is information on AIDS classification and deaths, so those diagnosed with AIDS, which are in green, and then the number of deaths, which are in orange. And again, you can see that up until the mid-90s, the rates were going up, and then they dropped dramatically once effective therapy was instituted, and then now pretty much they've leveled off, although the rates, as far as AIDS are concerned, continue to decline somewhat. And this is AIDS classification based on race and ethnicity. And you can see that African Americans are more disproportionately affected by HIV and AIDS than whites or Hispanics. Here's a graph looking at those living with HIV. So most patients with HIV, because of effective therapy, don't have AIDS now. So these are those living with HIV, and these are rates per 100,000 individuals. And you can pick your state or look to see what your rate is. The darker colors have the higher incidence. This is the rates of those living with HIV infection who were ever classified as AIDS. In other words, they were classified as having AIDS, and then maybe now they're on effective therapy and they no longer meet any of the criteria for AIDS, but at one point they were diagnosed with that. And again, this is per 100,000 individuals, darker colors, higher rates. And then finally, this is the number currently with AIDS, living with AIDS. Per 100,000. Obviously, this is the lowest number. These are the people who meet the criteria. And I do have the AIDS defining conditions on page 49, table 3, and so you can look at all those things that would mean that the patient does have AIDS. And then simply having a low CD4 count also puts you into the category of having AIDS. So a little about diagnosis of HIV, and this is located on page 48. The gold standard is now ELISA as the initial test, and then Western blot as the confirmation. However, there are a lot of rapid HIV tests. I have them listed there on page 48 if you want to read through those. There's a lot of different ones that utilize oral secretions or finger sticks or blood samples, etc., and they're very quick. They give you a result very quick, and they're actually very accurate as well, greater than 99% sensitivity and specificity. So they're very accurate, and the nice thing is you can test someone and get results while that person is still in your presence. And that was always the problem before, where people would be tested and then they would leave, and then you wouldn't be able to locate them and let them know if their test was positive. But now you can let them know, and then they can go for further testing and appropriate therapy where necessary. What really revolutionized HIV therapy was viral load testing, and viral load testing is obviously commonplace now, and I give you information on viral load testing again on page 48. Bottom line is whatever test you're using, less than 200 is considered undetectable, and that's your goal for your patients, to treat them until their viral load is undetectable and then remains undetectable. Now, when do you use that viral load testing? Well, there's certain situations. Acute infection, viral loads go up quickly with acute infections. Anyone who's newly diagnosed, to get a baseline viral load. And then a patient should be checked every 3 to 6 months and do a CD4 count at the same time. A little more often when you're starting therapy or changing therapy, because you want to make sure that therapy in that particular patient is appropriate and is working. And then finally, when there's any clinical event, infection or whatever, or that you notice their CD4 count is decreasing, you should get a viral load. But most of the time, you're going to be checking viral loads and CD4 counts on a regular basis anyway. All right. For the exam, you should review drug therapy. Recommendations on what to use can change. But the drugs themselves and characteristics of those drugs don't change, and so those are the things that you should probably be focusing on. There's a number of different categories, and I have those listed here. There's nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, entry inhibitors, and integrase inhibitors. So 6 different categories of agents. I have 4 of those agents in the tables on page 51 to 53. So within the tables, I have nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitor, non-nucleoside reverse transcriptase inhibitors, and the protease inhibitors. And then on page 50, I have information on the entry inhibitors and the agents that are now being used more and more, the integrase inhibitors. And those are on the bottom of page 50. On page 54, then, I have information on maternal fetal transmission, and the guidelines there are recommended based on the current situations of the pregnant woman. So the first situation would be an HIV-infected pregnant woman who is currently not receiving any antiretroviral therapy. So the recommendation at that point is to use potent combination antiretroviral therapy. As part of that combination therapy, ideally to use zidovudine. The recommendation to avoid efavirenz in the first trimester has now been taken away because the fetal damage done by efavirenz is generally done within the first few weeks of pregnancy before the woman would even know that she's pregnant. And so by the time she knows she's pregnant, you're already past the potential damage time. And so the recommendation is you can now use efavirenz at any point because the woman wouldn't even be diagnosed before the drug would be started. If the woman is already on antiretroviral therapy, you just continue that. And then the preferred regimen is listed there, lopinavir, ritonavir, plus zidovudine, lamivudine. That's sort of an old therapy. The recommendations are sort of old, and ideally simply having the woman on a regimen that decreases her viral load to undetectable is the ideal goal. The guidelines, when they come out, or the guidelines that are available have a nice section on potential issues with using antiretroviral therapy in pregnant women, and you want to make sure that you look through that. The big one is efavirenz, and even that has now been stricken because of the fact that the damage occurs very early on, even before the woman would know she's pregnant. Now, those receiving potent therapy should just continue with their current regimen, preferably with that would have zidovudine, and the reason you keep seeing zidovudine over and over again, even though it's not used as much anymore, is the fact that that was the drug, the first drug, and it was the drug that was initially used in the maternal fetal studies, and so that's the one that is still recommended. But again, if you have a woman who is on a regimen that is adequately controlling her, in other words, her viral load is undetectable, just continue that. You don't have to change to zidovudine at that point. HIV-infected women who are in labor, either those that present in labor who have never been on any therapy or those that are currently receiving therapy, you should start the zidovudine IV dosing guidelines, and again, that was from the initial study that was done way back in the late 80s, early 90s. That had IV dosing during labor, and that's still recommended unless, and this is new in the guidelines, that's why I bolded it, new in the February 12th guidelines, unless the women's viral load is less than 400. And if that's the case, you don't have to do this zidovudine IV. That woman is adequately controlled, and the chances of her passing on the virus are very, very low because her viral load is very, very low. During labor, though, you should still continue antiretrovirals. And then for the baby who's born to the mother who's HIV positive, zidovudine every 12 hours for 6 weeks. All right, I also give you post-exposure prophylaxis recommendations, which are very old as well. They need to be updated. Hopefully they'll be updated soon. And really that's not a problem as far as who should receive or post-exposure prophylaxis, but the agents you'll see that are recommended are more of the older agents. You'll notice that. And so whether to use post-exposure prophylaxis and what to use, either a 2-drug or a 3-drug regimen, depends on the type of exposure. So was it percutaneous or was it mucous membrane exposure, and then the severity of that exposure, and then the type of patient that you were exposed to. So if you're exposed to an HIV patient with a very low viral load, then you only have to use a 2-drug regimen. It's a lower exposure because their viral load is so low. But if your patient has a higher viral load, then you need to move on to a 3-drug regimen. All right, so off to our first case then. Case number 1, FG. FG is a 27-year-old male who is HIV positive, but he's asymptomatic. 1 year ago, his CD4 count was 815. His viral load was 1,500. He continues to be monitored, and now his CD4 count has decreased. His most recent one is 240, and his viral load is 60,000 copies. So how should FG be treated? A, no antiretroviral therapy because his CD4 count is still above 200. B, start him on zidovudine since his CD4 count is still above 200, in other words, zidovudine alone. C, start him on combination therapy of tenofovir, emtricitabine, and nevirapine. Or D, start him on tenofovir, emtricitabine, and a combination of boosted atazanavir with ritonavir. All right. Not very comfortable with HIV, are we? Okay, so let's talk about initiating therapy. And again, just a reminder that the new guidelines came out on February 12th. The recommendation is you should always start therapy in any of the following patients: a pregnant woman, those with a history of AIDS, those with a HIV-associated nephropathy, or a co-infection with Hep B. So regardless of what their CD4 count is, regardless of what their viral load is, you start therapy in those patients. Now, in all other patients, it's also recommended that you start therapy. And what they've now started doing in the guidelines is basically coding or grading their guidelines to allow a clinician to decide in that patient whether it should be used. So, in patients with a CD4 count less than 350, it's recommended to start therapy, and that's an A1 recommendation, which is the highest recommendation. Strong recommendation with really good data to back it up. If your patient is between 350 and 500, now it's an A2 recommendation, a strong recommendation, but the data is less good at recommending therapy in that particular patient population. Most clinicians would still start therapy, though. And finally, the last one is the most sort of controversial. That's a CD4 count greater than 500. That's a B3. And a B3 is a weaker recommendation that's basically based on expert opinion. So a moderate recommendation with expert opinion, not very strong. That's greater than 500. Now, the problem is that whenever you start someone on therapy, they have to be ready for that therapy because they have to be compliant, taking every dose, every drug when it's supposed to be taken. So if you have a patient and they might get side effects. So if you have a patient who's greater than 500, who's not ready to commit to therapy, who's concerned about side effects, you might want to wait a little longer. And if you have a patient who's greater than 500 but is really eager to start therapy and wants to stay healthy as long as possible, then again, that might be a patient who you want to start on therapy. Maybe they're concerned about transmitting the virus or whatever. Then that patient might be good for starting therapy. So it's really patient-specific when you start to get into the higher CD4 counts. But there's not any strong data that shows that starting someone greater than 500 is any better than waiting until their CD4 counts drop a little more. And then any patient who's really concerned about the risk of transmitting to a sexual partner, again, that regardless of CD4 count, you can start therapy. Now, preferred therapy is listed at the bottom of page 55, and the preferred therapy has not changed that much in quite a number of years, so it's been pretty stable for a number of years. And the preferred therapy is boosted atazanavir or boosted darunavir, so one of the protease inhibitors, one of the boosted protease inhibitors, plus tenofovir with either emtricitabine or lamivudine. And most people will start with emtricitabine because that comes in a combination product with tenofovir. Your other option is to use a non-nucleoside reverse transcriptase inhibitor. So instead of the protease inhibitor, a non-nuc, plus, again, tenofovir with either emtricitabine or lamivudine. Most people use tenofovir with emtricitabine. Or you can use an integrase inhibitor, and the first integrase inhibitor, raltegravir, that's the only one that's preferred therapy at this point, again, plus either tenofovir or emtricitabine, or plus tenofovir with either emtricitabine or lamivudine. So one of those agents, a protease inhibitor, a boosted protease inhibitor, specifically atazanavir or darunavir, or a non-nuc, specifically efavirenz, or an integrase inhibitor, specifically raltegravir, with that combination tenofovir and emtricitabine. Now, there are alternate therapy, but really you should start with one of the preferred therapies and only move to the alternative therapy if the patient cannot tolerate one of the preferred or for some reason can't take any of the preferred therapies, which is pretty rare. So an alternative therapy is, again, one of those boosted protease inhibitors with a different than nucleoside reverse transcriptase inhibitors, abacavir and lamivudine, or one of the lesser recommended protease inhibitors, boosted fosamprenavir or lopinavir, plus, again, the NRTI combos. Efavirenz or rilpivirine, which is another non-nuke, plus one of those nuke combos, or either of the integrase inhibitors, either raltegravir, the integrase inhibitor that's preferred, but with a different, less preferred nucleoside reverse transcriptase inhibitor combo, or the newest integrase inhibitor, L-vitagravir, plus tenofovir emtricitabine, which is actually a combination product, all four of those drugs, L-vitagravir, which is boosted with cobixistat, then tenofovir and emtricitabine. It's all one product, and so if you're going to take that, you're going to take that particular product. All right, we now move even farther down. So we started with preferred, went to alternative, and now we go to acceptable. And these are used in patients who resistance has developed, or they've had to move agents because of side effects or whatever. And so I'm not going to go through these in a lot of details, but you can read through them. It's the same sort of products, but used in different combinations. It might be a lesser preferred non-nucleoside, a lesser preferred protease inhibitor, a lesser preferred nucleoside reverse transcriptase inhibitor combination, whatever. Those are less preferred. Really, if you can focus on the preferred combinations, I would start with that, and that's probably good enough at this point to know those preferred combination agents. There are some regimens to be used with caution, and I have listed those there, and then not recommended therapy. You never use monotherapy in an HIV patient. You don't just use one of those dual NRTI regimens alone, and triple NRTI regimens are really no longer used and no longer recommended either. So, how should FG be treated? His CD4 is 240. 240 is less than 350. 350 is that A1 recommendation for treatment, so he definitely should be treated. So we can get rid of A, and then basically we would want to start with a preferred therapy. And the only one that's a preferred therapy, we never use a monotherapy, so B is incorrect. Triple therapy in C is okay, but nevirapine is not a preferred agent. It's only an acceptable agent. And so the correct answer would be D. Emtricitabine with tenofovir, and then the boosted protease inhibitor, atazanavir. Moving on to question 2. The CD4 count increases and viral load is undetectable. And then he stays on therapy, and then 2 years later he comes back, and now his CD4 is 310, and his viral load has gone from undetectable to 15,000 copies. So, what should we do? Make no changes, just wait until his viral load gets above 50,000. Change one agent, change the tenofovir to abacavir. Change two agents, change tenofovir emtricitabine to abacavir lamivudine. Or 3, change the entire regimen to abacavir, lamivudine, and boosted fosamprenavir. All right, maybe you don't like any of these answers. That could be positive. That's something to remember on the exam, too. They'll ask for the best answer of the choices you've been given. Don't get frustrated by it. I wouldn't do any of those things. I would do, something totally different. Well, you got to pick one of those agents, so keep that in mind. So when do we change therapy? Well, for virologic failure, you change it if after a few weeks to a few months, you are not becoming undetectable. Remember I told you when you check viral load, when you start or change therapy, as you're checking that viral load, if you're not getting to undetectable, you need to make changes because you should get to undetectable really quick with an effective regimen. If you have 2 consecutive viral loads that are more than 200 copies after 24 weeks of therapy, so in other words, you've been on 6 months of therapy, and now you're starting to get a detectable viral load twice. So you might get 1 detectable viral load, but it should go back to undetectable. But if you get 2 of those, then you need to change therapy. Or if you've initially gone to undetectable and then you get 1 greater than 200. Now, you also might change for immunologic failure when the CD4 count starts either didn't increase enough after you started therapy, or it didn't increase above 350 after you started therapy. And then once you have decided that, okay, this is a situation where we probably need to change therapy, you need to perform resistance testing, and this is primarily done in specialized clinics, because they're the ones that are used to reading those resistance testing. So perform resistance testing, and then based on that resistance testing, you can make changes. So if the patient has been on therapy, but there's no resistance, then usually it's a patient-specific issue. So it's usually that they're not being adherent, so they stop taking their drugs. And so check for that, address that, deal with it with the patient, and you can maybe even continue the same regimen. You can also start a new regimen or think about intensifying or boosting therapy if the patient isn't already on a boosted therapy. Now, if there is resistance that occurs, so you do the resistance testing and there is resistance, then you need to change your regimen. Based on the resistance testing, change it to a regimen that will be appropriate for that patient. And ideally, changing the entire regimen, changing all 3 agents. But you have to change at least 2 agents. Just like TB, just like we don't treat HIV with one drug, you never change just one drug unless it's due to a side effect. You can change one drug. But if it's due to efficacy, you don't change just one drug because resistance with the new drug will happen real quick. If they have been on extensive therapy, you've gone through many different agents and now they have resistance, then you just resuppress with whatever option you can come up with. And there's a lot more options now to pick from, which is nice. And if you just can't find any options that are going to be effective for the patient because of the resistance data, then sometimes you just have to continue with the current regimen and try to suppress as much as possible. The fortunate thing is with new entry inhibitors and new integrase inhibitors, where there's a lot of new options that people can go to when they're in the situation where resistance has developed. Resistance is much more likely to develop if the patient is non-adherent, so that's why the patient really has to be on board and is really going to take their drug every day, every dose when they need to take it. When they stop doing that, that's when resistance occurs. Unfortunately, we have a lot of new options now that allow for a very low pill burden, and because of the low pill burden, people are much more likely to be adherent. So, obviously this is a change. The viral load has gone up. He was initially undetectable, so we need to make changes. So A is out. We never want to change one drug, so B is out. And ideally, you want to change 3 drugs if at all possible. So the correct answer is to change the entire regimen to a different regimen. So which of the following should be monitored if FG is now to receive fosamprenavir, boosted fosamprenavir, so fosamprenavir with ritonavir? A, peripheral neuropathy. B, drug interactions of CYP1A2. C, endocrine disturbances, including hyperglycemia, fat redistribution, lipid abnormalities. Or D, nephrolithiasis. This is a type of question you're more likely to see on the exam because it's not one that's dependent on the guidelines. It's just dependent on you knowing your drugs. So the correct answer is C. Peripheral neuropathy is seen with some of the nucleoside reverse transcriptase inhibitors. There are a lot of drug interactions with protease inhibitors, but they're 3A4 drug interactions. And nephrolithiasis is a side effect that we saw with sequinavir when sequinavir was used, which it isn't anymore. So the correct answer is endocrine disturbances, which are quite common with protease inhibitors. All right, so that's treatment of HIV itself. And hopefully if you're treating your patients adequately with appropriate antiretroviral therapy, you won't see these opportunistic infections. But I know from my clinical practice I continue to see opportunistic infections, and primarily that's in people who are either A, newly diagnosed, or B, very non-adherent or not taking any antiretroviral therapy. Those are the patients that are going to get into problems and have these AIDS opportunistic infections. This graph is figure 1 on the top of page 58, and it just goes over when you start to see these infections based on CD4 counts. And that does have an impact as far as therapy is concerned, and especially important as far as prophylaxis is concerned. So 3 years later, FG's CD4 count has decreased to 135. What should he receive primary prophylaxis for? Pneumocystis pneumonia, cryptococcal meningitis, CMV, or Mycobacterium avium. So CD4 at 135. Okay, some answers there. So let's go over when we use primary prophylaxis. And I'm sure you're aware, primary prophylaxis is giving drugs to prevent an infection before the patient has had that infection. Now, I'm going to have the page numbers that each of these recommendations on. They're within the specific agent, so if you want, you can flip to each of these pages as they come up, but we're going to get to that organism in a little bit, and so you don't have to flip if you don't want to. For pneumocystis pneumonia, the recommendation is primary prophylaxis when CD4 counts drop below 200. For cryptococcal meningitis, no primary prophylaxis is indicated. And that's because the primary prophylaxis we would use would be fluconazole, and it's not recommended that you use fluconazole in patients for a long period of time because then many different resistant fungal infections can occur. CMV retinitis, the recommendation is primary prophylaxis when CD4 drops below 50. However, the primary prophylaxis does not involve drugs. It's just getting regular fundoscopic exams, and if you notice that the patient has CMV retinitis, then you start treatment. Next is MAC, or Mycobacterium avium complex. Primary prophylaxis is recommended when CD4 counts drop below 50, and the recommended therapy is listed there, either a macrolide or rifabutin, most of the time macrolide, most of the time azithromycin. And then finally, toxoplasmosis, primary prophylaxis is recommended when CD4 counts drop below 100. Recommended either Bactrim or trimethoprim sulfa or a combo of dapsopyrimethamine. So the correct answer, this patient is greater than 100 but less than 200, so the correct answer is A, pneumocystis. So let's talk about pneumocystis, PCP, and this is patient case 5, and the information on PCP begins in the middle of page 59. So BL, now we're moving to a different patient. We're moving past FG to BL. BL is a 44-year-old man who is HIV positive, comes to the emergency department severely short of breath. He is an extremely non-adherent patient and has not seen a health provider in more than 3 years. So this is, again, one of those tips that you'll see. HIV patient not taking medications, now you need to start thinking about opportunistic infections. Chest x-ray is done. He has pulmonary infiltrates in both lung fields, which is very pathognomonic for PCP. And you can see his labs there, which I won't read. They're pretty much within normal limits, except his LDH is elevated, which is very common in PCP. And he's not oxygenating very well. His PO2 is 63 and his O2 sat is 85%. At this time, his stains are all negative, but with PCP that's very common. It's hard to get a positive silver stain for PCP. So, how should BL be treated? IV pentamidine with adjuvant prednisone for 21 days, trimethoprim sulfa for 21 days, trimethoprim sulfa with adjuvant prednisone for 21 days, or atovaquone for 21 days. Okay, not a lot of people venturing to guess. So let's go through it so you will be able to understand it a little better. So PCP is caused by Pneumocystis jirovecii, which is a sort of a new name. It's no longer called Pneumocystis carinii. That's been for a number of years now, however. The agents that we use to treat PCP are trimethoprim sulfa, pentamidine, trimethoprim in combination with dapsone, used quite commonly in patients with sulfa allergies, atovaquone, or the combination of clindamycin and primaquine. And you can see there you have options for patients with sulfa allergies. Now, steroids are used as adjuvant therapy for severe PCP. Severe PCP is PCP accompanied by an AA gradient greater than 35 or a PO2 less than 70. So this patient had a PaO2 of 63, which is less than 70. An AA gradient at sea level is 150 minus the PO2 minus the PCO2, and so for him, his AA gradient is also elevated. So he does have a reason for using adjuvant prednisone. The recommended dose is 40 milligrams twice a day for 5 days, then once a day for 5 days, and then 20 milligrams for the remainder of the course. And we always treat PCP for 21 days. So the course of the steroid is also 21 days. 40 BID for 5, 40 a day for 5, 20 a day for the rest of the course. Prophylaxis, obviously whenever we have an opportunistic infection in an HIV-positive patient, we have to give them secondary prophylaxis after they've had the infection. And so we obviously have to do secondary prophylaxis. And then I mentioned primary prophylaxis in patients with CD4 count less than 200. In both of those instances, you can stop prophylaxis, either secondary or primary, if the CD4 count is greater than 200 for 3 or more months. So keep in mind there's these rules for each of these disease states, and those could be questions. So watch those rules. So stopping therapy for more than 200 CD4 count for more than 3 months. All right, so BL is, how should BL be treated? Well, we need to use adjuvant prednisone therapy, so that would be A or C, and then the primary therapy that's recommended is trimethoprim sulfa for 21 days. So the correct answer is C. All right, going from PCP, I have some information on Candida infections in your handout, page 61. And now we're going to move on to cryptococcosis. This is GH. GH is a 33-year-old HIV-positive male who presents to the clinic with a severe headache that has gradually worsened during the past 3 weeks. He has had some memory problems. He's very tired. His CD4 count is 75. So if you look at the graph, this does put him at risk of cryptococcosis, and he is diagnosed with cryptococcal meningitis and successfully treated. We'll talk about what those treatment regimens are. So he's been treated, and again, with any opportunistic infection, once you've had the infection, you need secondary prophylaxis. So which of the following is the most appropriate follow-up or secondary prophylaxis for GH? No maintenance treatment, fluconazole 200 a day, amphotericin IV once weekly, or as long as he takes his PCP prophylaxis, GH will be protected for cryptococcosis. All right. This is a little easier, hopefully, maybe. So let's talk about cryptococcosis. This is therapy now, not prophylaxis, but as far as treatment is concerned, the therapy recommendations are on page 62. The preferred therapy is amphotericin plus flucytosine for at least 2 weeks, followed by fluconazole for at least 8 weeks. So the combination amphotericin and flucytosine. And there was just a study, if you read New England Journal regularly, there was just a study that came out in the New England Journal about a month ago that looked at amphotericin alone versus ampho plus fluconazole versus ampho plus flucytosine, and confirmed once again that the best of those is amphotericin plus flucytosine, that combination therapy. You see the alternative I have there is amphotericin alone, and that is an alternative, but again, based on the study that just came out as well, that's still not the preferred therapy. And then another option is amphotericin plus fluconazole, but again, based on the study that just came out, that's not a preferred therapy either. And then other options, which are really down on the list, are high-dose fluconazole with flucytosine or high-dose fluconazole alone. And you can see these are hefty, hefty doses of fluconazole. Now, relapses occur very, very, very commonly with cryptococcal meningitis, and so you must put the patient on secondary prophylaxis. And the secondary prophylaxis is fluconazole, 200 milligrams once daily. Primary prophylaxis, remember, not indicated because we don't want a lot of people on primary prophylaxis because that would promote the development of resistance, especially Candida resistance. But if they've had the infection, they need to be on fluconazole. So the correct answer is B, fluconazole 200 milligrams daily. Now, after being treated for the cryptococcal meningitis, he started on potent therapy, GH. We're still on GH, same patient. This is question 7, top of page 63. And for 2, 6, and 8 months after starting his therapy, his CD4 counts went up. 2 months there at 212, 6 months there at 344, 8 months at 484. So the therapy, he's being adherent, is very effective. And what is then the best follow-up? To continue the fluconazole maintenance he's been on, to make sure that he stays on it for at least a year, then you can stop it since the CD4 counts have increased. To continue until the CD4 counts are greater than 500, or at this point, the maintenance therapy with fluconazole can be stopped. Okay, we're going to have more rules now for stopping. The rule for stopping is that secondary prophylaxis for Cryptococcus can be stopped if the CD4 count is greater than 100 for 3 months. And that was the case with this particular patient, so we know we can stop therapy. Remember, at PCP, it was greater than 200 for 3 months. Cryptococcal meningitis, it's greater than 100 for 3 months. And that's simply because of the fact if you're more than 100, you're not going to get cryptococcosis. And with PCP, if you're more than 200, you're not going to get PCP. So the correct answer then would be D, maintenance therapy can be stopped. All right, moving on to question 8, and Mycobacterium avium complex. This is JC. JC is a 36-year-old HIV-positive female. She has severe anemia. She's been tested for iron deficiency. She's been taken off zidovudine. She's been taken off trimethoprim sulfa. And she's also started to lose a lot of weight. And a blood culture is done, and it's positive for MAC, Mycobacterium avium. So how should JC be treated or prophylaxed for this infection? Clarithromycin plus ethambutol for 2 weeks, followed then by clarithromycin alone as maintenance therapy. Azithromycin plus ethambutol for at least 12 months. Clarithromycin plus INH for 2 weeks, followed again by that maintenance therapy with clarithromycin alone. Or ethambutol plus rifabutin for at least 12 months. This is a tougher question. Got at least one answer right. Someone got right. Couple more. All right, therapy for MAC. And then therapy for MAC is noted on the bottom of page 63, and then it spills over into the top of page 64. The recommendation is a macrolide, either clarithromycin or azithromycin. Azithromycin is a little easier dosing because it's once daily dosing, but either of the macrolides can be used, plus ethambutol. That is the recommended therapy, a macrolide plus ethambutol. And unless you have some reason that that can't be done in your patient, that should be the regimen that's used. Other agents that can be used instead include rifabutin, ciprofloxacin, amikacin, but again, a macrolide with ethambutol is the drugs of choice. Now, stopping. In the past, before there was highly active therapy, patients would just stay on their MAC therapy for the rest of their lives, and usually they didn't live that long because they were at the end of their course of disease. However, now with effective therapy, people live a very long time. And so the question is, what do we do as far as therapy is concerned? Because the recommendation was just treat forever. And the recommendation is still to treat forever. However, if the patient's CD4 count bounces back, and the recommendation here is greater than 100 for 6 months, and the patient is asymptomatic, you can stop therapy as long as you've treated for a year. So you have to treat for a year. Think of this like Mycobacterium tuberculosis. So it's a mycobacterium you have to treat for a long time. You have to treat for a year, and then at the end of that year, if their CD4 count has been greater than 100 for at least 6 months, you can stop. Otherwise, continue until their CD4 count is greater than 100 for at least 6 months. Primary prophylaxis is recommended, and I have listed there when the CD4 count is less than 50 and the agents that you can potentially use, and I mentioned azithromycin is most commonly used because of its once-weekly dosing. So how should JC be treated? Well, it's a macrolide and ethambutol for at least 12 months. So the correct answer is B. Okay, CMV. Case 9, last case, I believe, in HIV. So case 9 is PL. PL is a 44-year-old HIV-positive male who is diagnosed with CMV retinitis, currently on zidovudine, lamivudine, and efavirenz, also on dapsone and fluconazole as well. And what is the best empiric therapy for PL? Valganciclovir orally, and change the zidovudine, lamivudine to tenofovir M-tricytidine. Ganciclovir IV, and change the dapsone to atovaquone. Foscarnet IV, and change the efavirenz to atazanavir and ritonavir. Or acyclovir IV with no other changes. Okay. Got some answers out there. Correct answers. Let's go over therapy of CMV. The recommended therapy is oral valganciclovir. So valganciclovir is just a prodrug for ganciclovir. Valganciclovir can be given orally. It's generally well tolerated, and you use for 14 to 21 days. The only other option is an implant, an intraocular implant that has the valganciclovir or ganciclovir on it. Foscarnet can also be used, but it's an IV drug. It has to be used given quite frequently, so it's not very commonly used. Same thing with cidofovir. It's not given as much, but it's an IV drug, and so not used as much as the valganciclovir. Secondary prophylaxis also must be used once you've treated the patient with one of the three options, same three options, valganciclovir more commonly used. And again, the rule is stop if the CD4 count greater than 100 for greater than 3 months. So most of the stopping is greater than 3 months. There's a few that are 6 months, but most are greater than 3 months. Most are greater than 100 except for PCP, which is greater than 200. And then primary prophylaxis is just those regular exams, which I mentioned before. So the best agent is going to be valganciclovir. And you would need to change the zidovudine because zidovudine causes bone marrow suppression, as can ganciclovir or valganciclovir. And so it would be best to change that to a different agent that's not going to cause bone marrow suppression. Acyclovir has no activity against CMV, so it's not an effective agent. So the correct answer is A. Toxoplasmosis, last opportunistic infection, starts on page 67. I don't have a case for it, but there's information there that you can read through just as a refresher. Recommended therapy is pyrimethamine plus sulfadiazine, but for those patients who might have a sulfa allergy, you can use pyrimethamine plus Clinda, or pyrimethamine plus atovaquone, or pyrimethamine plus azithromycin. So one of those options with pyrimethamine. Primary prophylaxis, you do need to give primary prophylaxis when CD4 count drops below 100. The recommendation for primary prophylaxis is Bactrim, so if you're already using, or trimethoprim sulfa, so if you're already using that for PCP primary prophylaxis or secondary prophylaxis, you'll also get the benefit for toxoplasmosis. And then after you've treated, secondary prophylaxis is with one of the agents that you've used to treat, just at lower doses. And with Toxo, you stop again after 3 months of higher CD4s. And for Toxo, it's just like PCP, so the same recommendation, greater than 200 for greater than 3 months. Secondary prophylaxis is using one of the agents, as I mentioned before, that you use to treat, or one of the regimens that we use to treat, usually just at lower doses. And again, stopping, now for secondary prophylaxis, the recommendation is stopping greater than 200 for 6 months. As I complicated this with more than 100, more than 200, more than 6 months, more than 3 months. But the important thing to know is that you do stop primary and secondary prophylaxis when CD4 counts have gone up for an extended period of time. Hopefully there won't be any questions that are cruel enough to differentiate between 3 and 6 months. That would just be really cruel on your part. Okay, my last thing I'm going to spend time with, the last 10 minutes or so, is tuberculosis. Tuberculosis begins on page 68, and I have a lot of information on epidemiology, pathophysiology, and diagnosis. And just to go over a little bit on epidemiology, I have some slides from the CDC. These are the number of cases of TB in the U.S. from 1982 through 2011. And you can see that the rate continues to go down, and it's been going down for the past 30 years, except for the little HIV blip that you see there. So the time point where HIV began and before we had effective therapy, when TB rates went back up again, but now they've been going down consistently and hopefully will continue to go down. This is a map of the U.S. That looks at the national average and then splits, and that's per 100,000 people. So the average is 3.4 per 100,000 people. And so the blue states are those that are higher than the national average, and the white states are those that are lower than the national average. These go over cases of U.S.-born versus foreign-born individuals. And you can see that at the turn of the century, they sort of flipped. So it used to be more cases in U.S.-born individuals, and now it's more cases from foreign-born individuals. And you can see the rates in foreign-born individuals have stayed relatively constant, and the rates in U.S.-born individuals have gone down. So obviously it's in foreign-born individuals coming from countries where TB is endemic, and so it's very, very common for those individuals to be exposed earlier in their life. I have a whole algorithm there on pathophysiology that you can look through if you'd like. Diagnosis is made based on signs and symptoms. Chest x-ray is obviously very important, and then microbiology. Checking for acid-fast bacilli, which MTB is. You can also place a PPD, which most, if not all of you, have probably had before, to check to see whether you're reactive, whether you've been exposed to TB. And now we have newer blood tests that don't have some of the issues or problems related to doing PPD tests, like people that have been vaccinated with BCG, et cetera. And so a lot of places now are doing blood tests to test for exposure to TB. Now, latent TB infections are those patients who've been exposed but are not actively infected. And so latent TB infections can be diagnosed by doing a PPD and see if someone has been exposed. And based on the result of the PPD and other patient characteristics, then you treat the latent TB infection based on those results. So if you are placing a PPD and it's positive, and if it's at least 5 mils in duration, that means the bump is at least 5 millimeters, and the patients have any of these risk factors, so a positive chest x-ray, close contacts, patients with HIV, cellular immunity defects, etc., those people need to be treated for latent TB. If it's 10 or more, and they're an immigrant from a high prevalence area or IV drug user, etc., you can read those there, they need to be treated. And then finally, if it's 15 or more, they need to be treated. Anyone who's 15 or more, even those at low risk. But those at low risk for TB should not be tested. You should never test someone who has no risk factors for TB. You should only be testing those who have risk factors for TB. The only exception to that is healthcare providers, who get tested if they're working in an environment where they could be exposed to TB. So the most common low-risk patients that are going to have a positive PPD are going to be healthcare providers, because those are the only ones at low risk who would be tested to begin with. And as I mentioned, either the quantiferon gold or the T-spot test or the blood test that can be used instead of the PPD. So question 10, JM. JM is a 42-year-old male. He works at a long-term care facility, so he needs to be tested. He is tested, and he has an 18 millimeter in duration. So no other risk factors, but it's 18 millimeters. And it's his first PPD reaction. His chest x-ray is negative. What do you do? No treatment is necessary, another PPD in a year. Another PPD should be performed in 1 week to see if this is a booster effect. JM should be monitored closely, but no treatment is necessary because he's over the age of 35. Or D, start INH and treat him for 6 months. All right, most people have that answer, much to healthcare providers' chagrin. So therapy of latent TB is if you are PPD positive, and I've given you the guidelines in what is considered PPD positive, and you have any of these risk factors. And you notice one of them is healthcare worker at facilities with TB patients. So JM fits into that category, and his PPD is positive because it's more than 15. So he should be treated. And the recommended treatment for an HIV-negative patient is INH, either daily or twice weekly, for 6 to 9 months. 9 is preferred, but if you can get someone to take INH for 6 months, you're doing very good. So at least 6 months, although 9 is preferred. Age is no longer an issue. It used to be recommended that those over 35, because of the potential for hepatotoxicity, should not be treated, but age is not an issue anymore. Regardless of age, this is the recommended therapy. You can use rifampin if you want for 4 months, 600 a day, a combination of rifapentine and INH for 12 weeks, so that's cutting it down a little more. That's a newer recommendation. And then rifampin plus INH for 3 months. Again, a lower treatment time but more drugs is also a potential option. But INH alone for 9 months is still the recommended treatment of latent TB. HIV-positive patients are the same, pretty much the same recommendations, INH. It's just you have to do the full 9 months. You can't do the 6 months. So what is the best therapy for JM? Well, he needs to be treated, and the correct answer is D, start INH daily for 6 months. All right. Case 11, RJ. RJ is a 32-year-old HIV-positive male who presents to the clinic with increased weight loss and night sweats, as well as a cough productive of sputum. As I mentioned, he's HIV positive. He's currently on fosamprenavir, boosted with ritonavir, zidovudine, lamivudine, fluconazole, and Bactrim. He's positive for AFB, and he lives in an area that has a low incidence of multidrug-resistant TB. So what is the best therapy for RJ? Start INH rifampin PZA with no changes in his HIV meds. Start INH rifampin and PZA and increase the dose of fosamprenavir and rifampin. Start INH rifabutin, PZA, and ethambutol, and decrease the dose of rifabutin. Start INH rifabutin, pyrazinamide, and ethambutol, and decrease the dose of fosamprenavir. There's a lot of issues going on here with drug interactions, which is a main thing in patients, HIV patients with TB. They're hard to treat. There's a whole section in the HIV guidelines on treating the patient co-infected with TB, and so always read through that when you're dealing with this type of patient. So let's go back a little bit, though, and talk about recommended therapy of TB in HIV-negative patients. So the recommendation is 4 drugs, INH rifampin, PZA, or pyrazinamide, and ethambutol, 4 drugs for 2 months, followed by INH and rifampin for 4 months, so a total of 6 months of therapy. You can give daily dosing or twice weekly dosing or 3 times weekly dosing. Those are options. If you want to do less drugs, only 3 drugs, INH, ethambutol, and rifampin, you can do that, but then you need to treat for a total of 9 months. So 2 months with the triple drugs, and then INH and rifampin for 7 months. The HIV-positive recommendations are basically the same recommendations. So 2 months of 4 drugs, and then 4 months of 2 drugs. The only thing they take out is that twice weekly dosing. You have to do at least 3 times a week dosing. And you can use the triple drugs followed by 2 drugs for a total of 9 months. So you can see that the recommendations are basically the same. And just to note, there is a new agent that was just recently approved for drug-resistant TB. And I have that listed there on the slide. Now, what do you do in the HIV-positive patients? Well, you want to start antiretroviral therapy within 2 weeks of starting TB therapy. You don't want to use rifampin or rifapentine if a patient is on PIs or non-nukes, non-nucleoside reverse transcriptase inhibitors. The only exception is you can use rifampin with efavirenz, but otherwise you cannot use rifampin with non-nukes or PIs. You need to use rifabutin instead. And if the patient is on rifampin before you start any of those, there needs to be a washout period where the effects of the induction by rifampin have gone away. So you can substitute rifabutin, but you need to monitor HIV RNA levels or viral loads very closely in those patients. and the dose is 150 a day or 300 3 times a week. So the best therapy then is not A or B, because those each have rifampin, and this patient is on a PI. So the best therapy is rifabutin, and then what you're going to have to do is decrease the dose of rifabutin because the PI is going to affect the levels of rifabutin. So the correct answer is C. Start the 4-drug therapy and decrease the dose of rifabutin. And then how long should RJ be followed up? Again, the treatment is the same for HIV-positive patients as it is negative. So the treatment is 4 drugs for 2, followed by 2 drugs for 4. So treatment with the initial drug for 6 months, change to INH and rifamycin after 2 months, then treat for 18 to 24. Change to INH and rifamycin after 2 months for a total treatment of 6 months, monitor viral loads, or change to INH or rifamycin and either PZA or ethambutol, so stay on 3 drugs after 2 months for a total of 6 months. So the correct answer is C. It's the same thing, 4 drugs for 2, 2 drugs for 4. You just have to change that rifampin to rifabutin. All right, I have information on antifungal therapy, including amphotericin, all the azoles, and the newer echinocandins, so make sure you read through those if you're not familiar with them. And again, I will be up front for the next 10 minutes. I have to introduce your final speaker this morning, so I will have to break with questions after I introduce the final speaker. But I will be here for the final speaker, and if you have any questions after the next speaker, I'll stick around and I'll still be here at 12:20 if you want to ask me questions then. Thank you very much.